It's absolutely an honor to have been asked to give this lecture for y'all, and it's my pleasure to be able to talk. I will do my best to stay within the time constraints because I don't want lunch happening at 4 o'clock in the afternoon, and I'll just launch into it. I know that there's going to be questions. Gosh, I wish I was there in person to be able to, interact with you, but time just wouldn't allow. So I've been asked to talk about the Lyme disease testing. If we want the 30-second version of Lyme disease testing, it's really crappy, it's unreliable, and people are trying to make it better. And when people succeed in making it better, nobody cares and nobody is giving it any credence. So there's the nature of the talk. Let me move on. My disclosures. So I used to have relationships with commercial interests and do lecturing for industry and so on. But in 2022, December of 2022, I got sick. And a lot of my activities changed pretty dramatically at that time. And so now I have no outside relationships with industry. I really don't have anything to declare as a conflict of interest. I will put this notice from the Code of Ethics that identifies a recognition of the responsibility to give generally held opinions of the profession when interpreting scientific knowledge to the public, and when presenting an opinion that is contrary to the generally held opinion of the profession to so indicate. Let me just use that disclosure for the entire rest of my presentation to say that most of what you're going to hear from me is a deviation from what you would hear from most of the medical profession. Not that it's wrong, just that it's not what you would hear from them. This lecture is built heavily from my own lived experience. The opinions I'm expressing are my own and are not influenced by others. The practice of medicine is an imperfect art. It's done by imperfect human beings. We do our best. And for myself, to those of you who I have injured unintentionally with what I have done or what I've failed to do, I apologize on my behalf. I apologize on the behalf of my profession. So let's start with where physicians and where caregivers and care providers are placed when they're seeing a patient coming to get help for a condition. What is the expectation of what you're supposed to do? This is referred to as the standard of care. And the legal principles pertaining to the standard of care have been outlined very nicely in Canada by Supreme Court judgments and Court of then Queen's Bench judgments. It's now King's Bench. But this is an excerpt from a judgment from the Supreme Court of Canada. You are not meant to read everything on this slide. I'm leaning forward and putting my glasses on so that I can read the paragraph that starts with the words, a doctor. A doctor need not follow the procedure adopted by a unanimous majority of doctors. If a doctor follows a procedure adopted by a reputable minority of practitioners, it will suffice to disprove any inference of negligence. What that means is you're not obliged to follow guidelines that are adopted by the majority. What it means is as long as you're following the guidance of a reputable minority, you can practice without fear of being called negligent. A judgment more recently than this in the Queen's Bench Court in Alberta on a malpractice case identified the following principles, and I've just highlighted them here. Choosing a diagnostic process based on probability rather than severity is fundamentally flawed and negligent. And the second quote here is failing to consider the worst first principle and then failing to carry out appropriate tests to confirm or eliminate the worst of the potential diagnoses is not a mere error of judgment, but rather it's a breach in the standard of care. So the court has made it really pretty clear that our job as practitioners is to identify what is the worst potential condition that a person has, and then do our testing to either confirm that it's present or eliminate it from consideration. And extending from that, if you can do neither, if you cannot confirm that it's present or eliminate it from contention, then you're obliged to include treatment of that condition in your treatment course. The college in Ontario has sent out letters regarding Lyme disease diagnosis and treatment. In 2019, they sent out this letter that identified that the college does not communicate specific expectations for treatment of Lyme disease. Physicians who treat Lyme disease are expected to practice in a manner that is informed by evidence and science and in keeping with relevant professional, ethical, and legal obligations. And those obligations, as I just outlined, can include following the advice and the practice of a reputable minority of professions. And foremost amongst the obligations for a practitioner is the duty to act in the best interest of the patient. So that is how we're judged. That's how I judge myself. Am I doing what's in this individual patient's best interest? So what are we supposed to do? We take a history. We do a physical examination. We make a clinical diagnosis and refine that clinical diagnosis by focusing our laboratory investigations, always with the intention of acting in the best interest of the patient. And the standard of care requires that the physician does what's reasonable, what a reasonable physician would do in the same circumstances. It doesn't require that you get a good outcome. It simply requires that you do what is reasonable. Now, doctors are trained by more senior doctors. And as time has gone along, there has been an evolution in what I see in practitioners. And this is from a poll that was done about a decade ago, looking at people hiring college graduates and identifying the greatest deficit that was present amongst college graduates entering the general job market, not just doctors. And lack of critical thinking and problem solving was identified as the largest deficit in graduates of higher education. The lack of ability to critically think and problem solve, identified by 60% of those hiring college grads. We rely on critical thinking ability to construct a medical differential diagnosis and to coordinate an investigative plan. And so if these college trainees are coming into their medical training with the lack of ability to critically think or problem solve, and if they're being taught by people who lack the ability to critically think or problem solve, then they're going to get their MD degree without the ability to critically think and problem solve. The ability to do this type of thinking dates back to at the time of Aristotle. Now, it's called deductive reasoning. What we see in medicine today is we see people following guidelines. Guidelines come from clinical experimentation. Clinical experiments give us certain things about diseases that we can identify and quantitate, and then we induce general principles about diseases and communicate that in guidelines. That the guidelines are really unhelpful to individuals. Guidelines really speak to populations or crowds of people, not to individuals. In order to apply treatment to an individual, we have to take those general principles and we have to deduce how they apply to each individual patient. This requires critical thinking. This requires the ability to distill the information from a guideline into what would be in the best interest of an individual patient. And this is frequently lacking. Frequently, you just hear it, the guidelines don't allow it, period. That is supposed to be the solution, I guess. So we have this cycle of general principles being able to be deduced to help specific instances for individual patients. And then we have clusters and groups of individual patients that we call control groups or that we call experimental groups. and we do experiments, population experiments, to induce more general principles. And so the construct of science requires both arms of this. And unfortunately, the deductive arm, where we boil down general principles to apply to individuals, seems to be, unfortunately, frequently neglected or lacking. This is simply Dr. Watson saying to Sherlock Holmes that he remembers when he used to answer questions using his powers of deduction rather than the Google search. But there is something that comes from Sir Arthur Conan Doyle's writing about Sherlock Holmes, and this is something that I actually make use of in my clinical practice of medicine. And this is the deduction that when you've eliminated all which is impossible, then whatever remains, however improbable, must be the truth. And this is something that I rely upon in my practice. So I'm frequently asked by people, shouldn't Lyme disease just be made by clinical diagnosis? And the answer to that is, I guess, maybe. A clinical diagnosis is established for any disease by taking a medical history first and foremost. The history of any disease is the most important feature of what a physician can do when seeing a patient for the first time. And a medical history, when properly taken, can provide you with a diagnosis correctly in over 80% of cases. Then a physical examination focused by your history will provide insight into your diagnosis in another perhaps 10 or 15% of cases. And so when you get to the point of doing laboratory testing, you're testing the probability that your clinical diagnosis that you've already probably established is present or not. It's not like you're setting out a fishing net and just trying to catch whatever is there. No, what you're doing with a test is you're trying to either prove or disprove, establish or negate a potential differential diagnosis so that you can follow through with what your obligation is. The worst possible situation needs to be either confirmed or eliminated, and this is where testing is often used. But the history is profoundly important. Sir William Osler, Canadian physician, knighted by Queen Victoria and identified as the father of modern medicine, and certainly is the father of modern internal medicine, the way that it is practiced, specialty medicine, famously is quoted as saying, "Listen to the patient. He is telling you the diagnosis." And this is true. If you do a good focused history, you'll get a very accurate, properly focused differential diagnosis to pursue. So this gets us now into contemporary management of Lyme disease. And the medical history in Lyme disease has been beautifully outlined in a very scientifically validated way by the Horowitz Medical Questionnaire. Kudos to Dr. Horowitz to take a questionnaire of the symptoms that are common, to come up with a questionnaire giving a numerical value to each of the questions, and then to subject it to a validation process that allows you to know what the sensitivity and specificity of this test is. So profoundly, profoundly useful and helpful tool when it's properly focused. This questionnaire has the sensitivity to identify Lyme disease in 81.7% of cases and a specificity of 90.2%. Now, those two terms in medical testing are profoundly important. So I'm going to talk about them for a second. Sensitivity means that a test is applied, and what's the likelihood that a person who truly has the disease will get a positive test result? Now, I cannot see the audience right now, but I'm going to ask everyone to put up your hand. And now that the hands are up, I have with 100% sensitivity identified every single person in the room who will eventually be hit by a bus. Unfortunately, that's not a very specific test. You can put your hands down now. Not a very specific test because not everyone who raised their hand is going to get hit by a bus, but everyone who's going to get hit by a bus raised their hand. So it was a sensitive test for bus hitting, but it's not very specific. And specificity means that only the people with the disease will have a positive test. And specificity is actually more important when we're dealing with Lyme disease than sensitivity is, in the context that we want to be able to prove to other specialists, we want to be able to prove to authorities, we want to be able to prove to governing bodies, we want to be able to prove to those who pay for insurance that when we say that the disease is present, that it is present with sufficient specificity that we can say we're really confident that this is the right diagnosis. Don't worry about the LR things at the bottom there. I'll get into what that means shortly. So let's look at the Horowitz Medical Questionnaire as a test. It has sensitivity, it has a specificity, it has what's called a positive predictive value and a negative predictive value. I'll get into that in a moment too. So there is our history taking pertaining to Lyme. Now let's go to physical examination. Here's a classic bullseye rash with multiple rings. This is such a beautiful picture. No one who knows Lyme disease would look at this rash and not make a diagnosis. The classic erythema migrans rash is the main clinical feature of Lyme disease. Unfortunately, this classic finding is identified poorly by those who don't have medical education, and it is recognized imperfectly by primary care providers in Canada as well. And from a clinical publication of about a decade ago, looking at 100 people presenting to a primary care physician in Canada with an erythema migrans rash and the accompanying history, 70 out of the 100 would be recognized as having an erythema migrans rash, diagnostic of Lyme disease. Decision at that point is treat. But only 58% of those 70 people will actually have treatment initiated immediately. The other people, the other 42%, will inappropriately have serologic testing recommended rather than treatment. So when we look at 100 people presenting in Canada with classical erythema migrans, the minority are being correctly identified and managed correctly with treatment. So now we get into the diagnostic tests, and I'm asked to talk about public and private testing, when to use, etc. The private testing has been focused in a way that the sensitivity is going up, the specificity is improving, the tests are becoming more reliable, and the problem is that the general medical consensus of experts is that they do not accept that testing because they believe that the testing is unreliable due to commercial interests of the laboratories that are developing the tests. The only way for tests to be adopted by the establishment is for the establishment to be given the methodology and to be applied to populations of standardized patients so that the validity of the testing can be documented by establishment doctors. Now, obviously, a private laboratory who's got a proprietary interest in their own test methodology isn't going to just willy-nilly share their technology with academia. And so there's the problem. It's not that the testing isn't available, it's just that the testing and the results aren't believed. So the core problems, many core problems, but tests give us imperfect information. The state of the art right now for testing in Canada is the modified two-tier testing method, where the first tier of testing is a fairly sensitive ELISA-based test that looks at a specific antigen that is expressed by Borrelia. And then the second test is a whole cell sonicate test, also a type of ELISA test. So it's two ELISAs that are done in series. And when you do testing in series, you lose patients because of the insensitivity of each method. So the sensitivity goes down, the specificity goes up. So a positive modified two-tier test has a specificity of well over 99%, but the sensitivity of that testing is probably in the low 60% range. So we have imperfect information from testing, and we have inherent uncertainty when we see a test result. If we see someone with an erythema migrans rash and we send them for serologic testing, and that serologic testing is negative, that shouldn't dissuade us from a diagnosis of Lyme disease, but often it does, because it injects the uncertainty of the false negative test result. So the critical questions about diagnostic testing: are we using it to rule in a diagnosis that we're already considering? Are we using it to rule out a diagnosis that we consider to be quite unlikely? Are we using it to get help with deciding whether we should or shouldn't be thinking about a diagnosis because we just don't have a clue? Are we using it to justify a diagnosis to a third party, like an insurer, or to another physician who may not be prepared to accept a diagnosis without a test result? Or are we using this test to decide whether or not a patient meets a threshold to make a diagnosis or a threshold to treat them? And so the diagnosis that emerges from this way of looking at test results, you'll get definite positives. You'll get some who don't meet the likelihood of having a positive test result to the same strength. And then you'll have a large group of people where the disease is plausible, but where the testing doesn't give you the majority likelihood that the disease is present. And let me just try and put that in words here. So the definite test results are what, our medical establishment is looking for. The results beyond any reasonable doubt. Status quo testing that looks at two-tier testing or modified two-tier testing or actual culture of the organism. Those are definitely diagnostic test results. Then we've got tests that would give you a likelihood greater than 50% that the disease is present, but not to the degree of certainty. And if you had a couple of tests that were positive that had likelihood ratios over 10, I'll talk about likelihood ratios in a minute, that would give you probable Lyme disease, but not a definitive diagnosis of Lyme disease. Most of the patients I deal with in my practice, though, don't fall into those two categories. Most of the patients that I see present with long histories of symptoms, maybe with tick exposure, maybe not with tick exposure, maybe with lower level test values that don't really give strength to a diagnosis of Lyme disease to the level that you'd be comfortable saying that it's a definitive or probable case of Lyme disease. And so we've got a couple of fundamental principles that need to be met by tests. So those fundamental principles are: can we drill a test down to give it words that make sense, which is what I've been trying to do for the last 10 minutes? And can we identify when a test will change the management of the patient and when it won't? So it helps us to identify patients who should be treated and clinical outcomes. And in order for a test to be looked at in that fashion, we need to have what's called pre-test probability of disease. So much of testing depends upon what's the likelihood you got the disease in the first place before the test is ever done. And so pre-test probability has been identified in the medical literature. Beautiful report that came from the Netherlands a number of years ago, trying to understand Lyme borreliosis in the context of what's the likelihood of things that we can look at the time of a bite that will predict whether or not the person's going to have Lyme disease. And here's the reference that's available in this slide. I'm not sure what slide number I'm up to, but you all will have access to the copies of the slide. This is slide 33. So this is the actual research article looking at this equation. And I'm not going to talk about how they identified their patients. Most of the bites in their study came from adult ticks. There's a large number of nymphal ticks. There's only a small smattering of larval ticks. And this is the likelihood of having Borrelia in a tick based on the life stage that the tick had achieved. So you can see that nymphs and adults had pretty substantial positivity for Lyme disease in this population that we're looked at. And the overall risk, if we eliminate all other predictors, is a 2.6% likelihood of developing Lyme disease after a tick bite, period. So for a pre-test probability, if you know nothing else about the tick bite, this is a legitimate estimate of your pre-testing probability of disease. We then do an analysis using something called Bayes' theorem. Bayes' theorem applies the sensitivity and specificity of a test to the pretest probability, and it spits out what the post-test probability of disease is if the test is positive or negative. So the HMQ is the Horowitz Medical Questionnaire, and what influence does it have on a diagnosis of Lyme disease after a tick bite? And so we put the 2.6% prevalence of disease, 81% sensitivity of the Horowitz test, and 90.2% specificity. Now, the cutoff that they used to generate this sensitivity and specificity was a Horowitz score of 36. So 36 and higher was considered probable enough to give it a positive result. And using this, we have the pre-test probability of Lyme of 2.6%. The post-test probability went up to 18% if you had a positive test result. And the negative predictive value was 99.5%. So the likelihood of you having Lyme disease with a negative Horowitz Medical Questionnaire goes down to 0.5%. Now, when we're looking at the threshold to treat a patient, when we're looking at the threshold to make a diagnosis in the patient, I am looking for the ability to say, do I have enough information that I can confidently, with 95% confidence, reject a diagnosis? This accepts that 1 time out of 20, that rejection will be wrong. But do I have, on the basis of a tick bite history and a positive Horowitz questionnaire, do I have enough evidence that I cannot reject a diagnosis of Lyme disease? If the Horowitz questionnaire is positive, I cannot reject the diagnosis of Lyme. If the Horowitz questionnaire is negative, then the likelihood of Lyme disease as a diagnosis is 0.5%. That's in a range where you may justify more testing. If the likelihood is less than 0.5%, I'm inclined to just drop it and not pursue it further. If the likelihood is as low as 0.5%, but 0.5 or higher, I will often engage another test. And so what is the impact of attachment duration on the pretest probability? This is again from that study. So a tick that's been attached for 4 days, the likelihood of Lyme disease in that situation goes up to 5.2%. You're hearing my little partner in the background here. 5.2%. So a 5.2% likelihood of having Lyme disease reaches the treatment threshold. If you've had a tick that you know has been attached for more than 4 days, that meets the treatment threshold right there. It's over 5%. What's engorgement do to the likelihood of Lyme disease? So engorgement, if you have a low engorged tick that hasn't been attached very long, we're talking about a 1.4% risk. If you have a substantially engorged tick, it can go up to as high as 14%. And what is the likelihood of looking at the DNA detection in the tick? So if you have a positive tick for Borrelia DNA, this doesn't guarantee that you have a risk that you have Lyme disease after a bite, but it does increase your risk, relatively speaking, by about 5-fold. So let's take the situation using the Horowitz questionnaire in a patient with a tick bite, less than 12 hours, tick not engorged. The tick was saved and sent for the PCR testing, and it was a negative test result. So we have the lowest risk tick that we can have, a 1.4% likelihood. We apply the Horowitz questionnaire, and the post-test probability of Lyme disease with a positive Horowitz questionnaire is 10.6%. The negative predictive value in this situation is 99.7%. So a low-risk tick bite like this, less than 12 hours, not engorged, negative PCR, negative Horowitz questionnaire, the likelihood that Lyme disease is going to emerge is 0.3%. That falls below my test further threshold. I would not explore further testing in this situation. You're only going to inject uncertainty because a positive test is probably not going to increase your likelihood to the 5% treatment range. I'm going to skip through these. I want to get to something different. So the idea of the threshold for treatment. So C in this equation stands for the cost, and B in this equation stands for benefit. And anytime you're going to treat anybody for anything, it's a cost-benefit calculation. What is the cost divided by cost plus benefit? So if the cost is 1 out of 20 patients getting injured, and the benefit is 19 out of 20 patients getting benefit, the cost over benefit is 1 over 20. That's a 5% cost to benefit ratio. That's a highly advantageous treatment to be using. On the other hand, if you're using a very costly treatment that hurts people, the cost might be 19 out of 20. Benefit might be only one person being helped without disadvantage. And so the cost benefit is a 95% ratio. That's a high cost to benefit ratio that probably wouldn't be engaged by most payers, etc. So it's a theoretical concept, and it's based on how harsh is the treatment, how likely are side effects, how costly is the treatment. So if we look at some of the genetic therapies that are being applied today, where it's hundreds of thousands of dollars per treatment course, cost benefit is it's a very high ratio. If we're looking at using generic tetracycline to treat late stage borreliosis, that's a very low cost to benefit ratio that should probably be explored. So I've been asked to also talk about what tests might be available in our jurisdictions that don't require special labs, that could be done easily. And so I looked at the literature. This is now deductive reasoning. I looked at the literature, looking at readily available blood tests that are known to be abnormal during at least early localized and early disseminated phases of Lyme. And to screen for Lyme disease, it's important to use only the tests that have high specificity to rule in the Lyme diagnosis. So I looked at a few tests, and the ones I'd like to talk about, the C-reactive protein can be ordered by any doctor without any special modifications. It's known to be a marker for general inflammatory disease. In patients with early and intermediate stages of Lyme, It has a sensitivity of 25%. So a quarter of patients with early and intermediate stage Lyme would have a positive C-reactive protein. And interestingly, the study that I pulled this from, it had a specificity compared to normal controls of 97%. So a high specificity, but not terribly high sensitivity test. Second one, the absolute lymphocyte count, which is part of the routine complete blood count that's done every time you get blood testing, probably. If that absolute lymphocyte count is reduced to less than 1,000, it had a sensitivity of 23% and a specificity that was, again, close to 97% in this population. And the third thing that I looked at was a reference of patients who had liver function tests, and those were specifically the 5 tests of alkaline phosphatase, AST enzyme, ALT enzyme, GGT enzyme, and the bilirubin level. And if 2 of those were abnormally elevated, that was seen in 27% of patients with a specificity of 96%. Now, if we combine tests, the way to combine tests to run them in a parallel fashion is you multiply the specificity of the tests and you look at the sensitivity by multiplying 1 minus the sensitivity for each of the tests. And when this is done, this has a positive value of 58% sensitivity with a 90% specificity for Lyme disease. If we did all 3 of these tests in parallel at the same time, and these can be done by any physician with any laboratory, you don't have to say why you're doing them. You just get a complete blood count to get your lymphocyte count. You get a C-reactive protein. You do standard liver tests. You're looking for abnormalities. So please let me introduce what I am calling for the first time, by deductive reasoning, the CALI-2 test panel. And the CALI-2 test panel includes the C for C-reactive protein, the AL for the absolute lymphocyte count, and the LE2, identifying that you need to have 2 abnormalities of liver enzymes, specifically looking at those 5. And if we run these in parallel, we get a sensitivity of 58% with a specificity of 90%. Now, I'd like to compare that to the sensitivity of the modified 2-tier testing that's the current state of the art in Canada. The modified 2-tier testing has a sensitivity of 56%, and the specificity of modified 2-tier testing is felt to be 98.5%. So it's less specific than 2-tier testing, but it's a test that you can run as a practitioner without raising any red flags. And it's got a decent positive likelihood ratio of 5.8%. So you can use it to rule in disease, actually still pretty effectively. The likelihood ratio is a formula that we use for calculating the probability that an individual has the condition with the test result over the probability of the individual without the condition having the test result. So the positive likelihood ratio is the likelihood that when you get that positive test result, you're getting it. How trustworthy is that as the result? And so 58% probability is actually pretty good. If we used tossing a coin as our test, 50% of the time it would be right, 50% of the time it would be wrong. The likelihood ratio of a coin flip is 1. And here's how the likelihood ratios stack up. If you have a likelihood ratio greater than 10, that's typically a large and often conclusive increase in the likelihood of a disease. If it's between 5 and 10, you have a moderate increase in the likelihood of disease. This is where the CALI-2 test panel actually falls. If your test has a likelihood ratio between 2 and 5, small increase in the likelihood of disease. If it's between 1 and 2, it really shouldn't change your thinking or management. And the same if you're looking at negative likelihoods. The likelihood that becomes important is likelihoods less than 0.2. So our Cali test panel with its likelihood of 0.5 really doesn't reduce our suspicion of disease. A positive result increases our suspicion. A negative result doesn't assuage that. So how do our tests line up? Well, if we did the old C6 ELISA, if we do the new VLAC ELISA, the sensitivities and specificities aren't much different. Likelihood ratio is really high, really good at ruling in disease. Likelihood ratio of a negative test, not low enough to be able to legitimately rule out the disease. So you can't rule out these diseases with negative test results. An IgM blood, same idea. IgG blood, same idea. The two-tier testing using CDC criteria, not a strong enough negative likelihood ratio to be able to rule out disease. The C6 plus an ELISA, so this is a modified two-tier testing, not strong enough to rule out disease on the basis of its negative likelihood ratio, because the tests are just not sensitive enough when they're put together. Here's other tests that people may do. The Lab B that I refer to here comes from a paper by Dr. Fallon, who looked at a number of laboratories. I'm wrapping up real quick here, I promise. The Lab B was a lab that used IGeneX's definitions for a positive test. It used IGeneX's definitions for disease positivity, and it was identified as being a private lab in his paper. I cannot say conclusively that Lab B is IGeneX, but I certainly have a greater than plausible likelihood. So I have strong suspicion that Lab B was the IGeneX lab. So the IgG blot using the CDC rules, likelihood ratio not strong enough with IGeneX to rule out disease. Its likelihood ratio for a positive result is not above 10. So it's in the moderate, not strong evidence range. IgG blot using Lab B's own in-house rules, less sensitive. The IgM blot using the CDC rules, not helpful. IgM from Lab B, these are really very, very minimal numbers, both for positive and negative testing. The IgM results using Lab B rules really are not helpful to me. The urinary nanotrap has got a published sensitivity and specificity. I don't see people ever having the test results in my practice, but it only has a small impact. The test called ELISpot from the Armin Labs in Germany publishes a sensitivity of 84%, specificity of 92%. Its likelihood ratio for a positive test is over 10. Its likelihood ratio for a negative test is less than 0.2. It is profoundly helpful in making decisions. PCRs are not sensitive enough to be able to rule out disease, but when they're positive, you can go to the bank with it. So simply say, please look at my slides later. ELISpot is my most helpful test because of its having both a strong positive and strong negative likelihood ratio. There's a lot of new tests that are coming out now that have got really strong positive and negative test results. But are they good enough tests that they're going to change the perception of our medical establishment to accept them? And the answer is probably not. Most, if not all, private testing results for Lyme disease are not and probably will never be accepted by mainstream authorities until they get the technology to experiment and publish them. And that's where we sit with testing. So the path forward, tests need to be considered in context. You need more than just a positive or negative test result. You also need to know what the performance of the test is in patients like you. The probability theory that I've tried to outline here is how I make my medical decisions. If you reach that medical threshold of 5% or greater, I'm comfortable to say I can't rule out Lyme disease. I need to treat you. And the treatment meets that cost benefit analysis because the cost of using oral therapies like I use in my practice is not prohibitive. And I'd like to also remind you of the CALI-2 testing panel, which is something that can be offered to patients who have no other avenue for testing. I've gone over my time for sure now, so I'm sorry for that. Whatever time is available for questions, I'm open for that. And thank you very much for your attention. You're very kind to have asked me to talk to you. I have this great wish for people afflicted with this disease to get their old lives back. Many of you won't. And for that, I'm truly, truly sorry. I'll help you live your best life that I can. Thank you.